But let's start with value-based healthcare. To start the introduction of value-based healthcare, great minds have been able to summarize complicated theories and complicated matter and condense it into a simple formula. You see Isaac Newton, you see Albert Einstein, and I think Porter and Thijsberg together did something similar. They summarized or they condensed a very complex field of delivering healthcare into a very simple formula, the formula of value determined by outcomes and costs. I'll give a more extensive introduction. There is lots of variation in clinical medicine, and these are data of a few years ago. And what you see, there's two times variation in survival in severe diseases like colorectal cancer surgery, up to 20 or 30 times variation in cataract surgery, in hip surgery, in large procedures. We do have these differences, and we could say, well, we should be ashamed that there are so many differences, but we could also use it as a challenge and use it as a chance and realize that variation helped us develop the biology we have, and the variation, it drives the evolution, as Darwin has described. So we can really use the variations and see where we can improve. And somehow I'm having troubles moving to the next slide. Here we go. And if we want to look at variations in outcome, we also have to think of the type of outcome we want to look at. And normally, especially in larger procedures, we look at survival, we look at mortality. And here's an example from urology to have something neutral. And you can see the differences in 5-year survival between the German national level, the Swedish national level, and one single clinic hardly show any differences. However, if you go to other outcomes, which might be very important for patients, like continence 1 year after surgery, erectile dysfunction 1 year after surgery, you see major differences in outcomes which are not as hard as survival is, but might be very, very important. So we also have to look at outcomes different from the very hard survival and mortality rates. And then there is another problem. A problem we have faced in all our Western countries is that spending on healthcare outpasses the spending or the growth in the gross domestic product. And that is something you can afford as a country for a while, but you have to start thinking how to tackle this problem. And in theory, there are 3 possible solutions. You can keep increasing healthcare spending, which won't be sustainable in the end. You do need money for schooling, for your roads, for your army. And the other approach could be to just put a lock on your front door and start rationing, which is not really ethically, it's not something we should do, and it might be politically difficult. The waiting times will increase and you might miss early stages of diseases. So if there is a theory which promises to increase efficiency, to improve the outcomes, and at the same time reduces cost, it's attractive, both for practitioners and their patients at the micro level, for hospitals at the meso level, and for governments at the macro level. Can we combine all these outcomes? And that's the promise Michael Porter did in his, and we should realize he's coming from the Harvard Business School, so it's a business theory where he proposed to have competition on results, but also on finances, to improve healthcare, but also to keep the growth of the funding and keep the growth, restrain the growth of the budgets. How did he do so? By proposing the theme of value. And actually, in the first slide, I introduced 3 formulas. In a real mathematical formula, you have same type of outcomes on both sides of the formula, which we don't really have here. Health outcomes are a completely different entity than costs are, but you can discuss how you can obtain value by doing the right things, which is effectiveness, reaching outcomes which are important for patients, and also delivering the healthcare in an efficient way, doing it with the right cost and at least not too much costs at the right place by the right people. And in this way, you can unite the interests both of the practitioners and their patients in the office, the interests of hospitals and the interests of society. And that's why many people think this is an attractive theory. What happens? I think in the office, we provide optimal care. There's a lot of focus on shared decision making, which care is appropriate for which patients. On the level of a provider of a hospital, you can design how to deliver the care, and I think Deepak will show some more on that. And on this level of society, we try to keep the healthcare costs low and try to organize healthcare in such a way that we are able to keep it staffed. And to do so, Porter suggested an agenda of 6 points to integrate, to coordinate and organize care in integrated practice units, to measure outcomes, but also to measure cost, to be able to argue whether you do or you don't obtain value for patients, to reconsider your payment model in order to pay for quality rather than paying for volume, to integrate systems between primary care, secondary, tertiary care, and then something more American, to expand the geographical reach. I think it's more difficult in densely populated countries like the Netherlands. And what's always challenge is to enable and to provide an adequate information technology platform. And actually, your next speaker suggested to expand this agenda and to organize, Paul van der Nat, an elegant paper suggested to organize quality improvement as well, to use this system and to use these data in patient communication, again, integrating care, but also to invest in the culture needed and to provide learning platforms as we did with the Linnean Initiative. And of course, if there is a new way of thinking, there's also critique. There's lots of critique on value-based healthcare, and I want to take you along. There is the critique that it's mainly a way of delivering healthcare. There is the critique that it's just patient empowerment. There is the critique that it's a governance discourse to reduce costs, and there is the critique that it really designs the world in a way that everything is manufacturable. And if you take these critiques together, if they're all true, I think we're doing a pretty good job in combining and connecting both the patient empowerment and the professional way of healthcare delivery and keeping healthcare sustainable. And a common denominator, which was not as much mentioned by Porter, was the shared decision making, which is really an important issue. And then to a final slide, to summarize it all, it's really about effective care which helps the patient obtain those goals which are important for an individual patient, to organize your care efficiently. And if you have less complications, your care is more efficiently. And if I take some distance and look at the interventions and the way of organizing care we are looking for, we should look at those interventions and those techniques where we improve the outcomes for patients and at the same time reduce the cost of treatment and reduce the burden of treatment for society. I think that's the challenge, and that's something I wish you all, that you can start thinking to your own way of working and look for those practice patterns, for those techniques which both improve outcomes for patients and simultaneously reduce the burden for society. Thank you.
Thank you so much, Willem Jan. It was really a great overview and really clear on the premise of value-based healthcare. And in theory, it's so elegantly simple, the formula, and I really appreciated the more famous formulas in the past. And I wanted to ask you, maybe in a couple of decades from now on, will they look back at the value-based healthcare as really a fundamental change in clinical medicine? What are your thoughts about that?
I think it fits in a time where we pay more attention to what's really important for patients. And it's not only value-based healthcare which does so. I think if you go back to the roots of evidence-based medicine, there is also the patient focus in there. And normally in evidence-based, there are three circles in evidence-based medicine. It's the evidence, the scientific evidence. And if we talk about evidence-based medicine, we normally focus on that topic, but it also contains focus on clinical, the clinical knowledge of the professionals. And there is this third item, which is part of the original idea of evidence-based medicine, is the patient preference. So I think there are several streams and several major ways of thinking, which all combine these aspects, and I think value-based healthcare is one of them. But it pays real attention to affordability as well. And actually, if we have the oath of Hippocrates, which something we all promise the day we graduate, it's all in there to focus on the interests of your patients, to look at the quality of care you're delivering, and to keep care accessible as well. So actually, you do promise to pay attention to all these aspects the day you graduate.
Yeah, I think we've all made that oath, and I think it also resonates with us, and to really strive for getting the best outcomes possible for our patients in our office, but also on a more broader national or societal level indeed.